Welcome to Healthy Veins, Healthy Legs, the only radio program that gives you a leg up on ways to identify and get help for ailments of the leg that can not only be cosmetically bothersome, but could actually be a big threat to your overall health and well-being. Now, here's your host, Mike Buck, along with Hawaii's senior vein specialist and vascular surgeon, Dr. Robert Kistner.
Well, hi there, and welcome once again to our program, Healthy Veins, Healthy Legs. We love bringing it to you, and we do this in order to educate you on what's going on those two very important appendages that you have in the lower section of your body called the legs. And today, Dr. Kistner and I are going to talk about all the folks that are encompassed by this disease and what some of the risks are, and more importantly, that how do you determine if you are a potential candidate to see a venous surgeon or your doctor just to get some answers. And it's sort of interesting because a lot of times, Dr. Kistner, over the length of time that we've been doing this radio program, we just assume that a lot of people are pretty primed up because I know about it as a patient and you know it as a practitioner, but there's a lot of people that they really don't even know. So today, we're just going to jump into vein disease 101. And by saying that, first of all, what the heck is vein disease? And why the word disease?
Well, why the word disease? That's a very good question. What is a disease? So a disease is something that isn't right.
Yeah.
and it tends to have legs, excuse the phrase, but it tends to last for a long time and may develop from one phase to another. So if we kind of use that for the definition of a disease, veins fit it very well, and we can outline that.
Yeah, and you have explained in the past, and we'll do it again today, that within this category of vein disease, there are a number of levels, some of which require surgery, some of which require no treatment but monitoring, some that just require Mother Nature to do her thing. So I guess within the word disease, and when we start talking about vein disease, what is a diseased vein? I mean, you know, what look does it have? What feel does it have? What symptoms does it have?
Well, we can kind of divide them into two kinds. One is the popular term is varicose veins, but varicose veins really represent a whole spectrum of problems that begin with little tiny spiders in the leg and progress all the way to huge problems with even sores on the lower leg due to the varicose vein. So this all comes under one term, Mike, called primary venous insufficiency, primary venous disease. Primary. And then if there's a primary, then there's a secondary. So secondary venous disease refers to blood clots. And so that's one way to take a look at it. So primary and secondary venous disease.
Okay, now, of course, the thing that comes to mind is today we have doctors and we have specialists in any number of areas, and specifically in the area of treatment of venous disease like you are, a venous surgeon. This is not something that is performed every day in every office. So general practitioners or internists realize that this has become a specialty. Why is that? What are some of the reasons that make vein disease, diagnosis and treatment a little bit more than, say, a superficial cut or somewhere where you need a stitch or a cast?
You know, it's kind of in the making at this point. Vein disease has been thought to be a simple thing of either a blood clot or a varicose vein in years past, but in the past several decades, it's been organized into a real specialty, if you will, not recognized as a medical specialty, but there are certainly people who have distinguished themselves by becoming specialists in the problem. And that's happened because all kinds of treatments have developed, both surgical and non-surgical, minimal surgical and maximal surgical, and so little injections and big operations.
One thing that I've learned since meeting you and not only being a patient but being the facilitator of the show is that I think, just as a layman observer, that maybe venous disease in years past wasn't as serious as it is because, frankly, we just didn't live as long as we are these days. And so the normal deterioration or breakdown, if you will, of the circulatory system was the last thing on the list. Other things got us. And now some of these other things are being either prevented or cured. And now we just got bodies that are aging and circulatory systems that are aging. It looks like that's where we start breaking down a little.
Well, you can say that, but in antiquity, there are all kinds of examples of pictures of people with vein ulcers and even varicose veins
as younger
back in
people.
Greek antiquity. So, the point is, it has been around a long time, but it hasn't been recognized for what it is. And one of the reasons for that is because it's such a slow developing problem. That is the varicose vein or the primary venous insufficiency. This will take. You can start with a little problem as a teenager and wind up with an ulcer due to that same problem 40 or 80 years later. So this is a very long-term run-out.
And, it also dawned on me that maybe we become, it's not maybe, we have become more sedentary. But people back in the days that you're talking about, if they had to go to a neighbor's house, they had to walk. If they had to, there was no such thing as a convenience store. It was inconvenient to go and get stuff. And we have taken so many crutches and so many aids and so many devices, and we don't saddle up the pony anymore. We get in a car and relax with an air conditioner on. So I'm not sure is that our bodies just, even though scientifically we've advanced to the point that we have, that our bodies are probably any better off than they used to be.
Well,
we just don't use them.
Yeah, a lot of dietitians and nutritionists would hate to hear that, but coming on facts is pretty difficult. But related to the veins, really has been major progress in the past 5 decades related to technology. And as technology has come along, what's happened is that it's become possible to look and see the veins as they're actually functioning within the body without doing anything other than putting an ultrasound probe on the vein.
Well, you talk often about when somebody presents. When you first see a patient for the first time, they present this, they present that. And obviously, we want to try to get into having people not necessarily 100% self-diagnose, but at least sort of think, well, maybe I'm a candidate. Maybe I have vein disease. Now, outside of the thing that we first talked about, which are these little spider veins which you can see, what are some of the other things that might happen to a person to indicate that they might have a venous disease?
Well, the major problem is swelling or pain, and in the venous problems, since they're on the surface of the skin, there's also cosmetic. So within those things, there's a whole range of problems. But to go back to what is the disease in the veins that causes a problem, basically it's a problem with the vein wall. And some of the problems we probably inherit as a genetic problem. Although we don't have a specific gene for vein disease, we do see it running in families. And so if your mom had varicose veins, you may or may not have them. If your mom and dad had them, you have a much better chance of having vein disease.
I've heard you say that you would be, in many cases, predisposed. In other words, there may not be a lot of preparatory things you can do to defer it. If it's going to come, you have to see how it comes and have it treated accordingly.
That's right. But what happens with the vein disease, when we look at them under the microscope, we can see certain changes in the vein wall that seem to be associated with development of or weakening of the wall of the vein. The vein is a beautiful, beautiful specimen of anatomy with specific layers of muscles in the vein wall, delicate little valves that function incredibly well and resist all kinds of pressure. But they come together as a very specific organ, and over time, little degeneration occurs so that some of that muscle tissue turns to fibrous tissue and it gets weaker, and then the vein wall dilates, and then the delicate valves don't work, and then you're off into varicose vein disease.
Okay, now we're going to talk about males and females, and one of the first things that comes to mind, and I know a lot of ladies want to know this right off the bat, as I said, that we're sedentary in comparison to our ancestors. We ride, we drive, we ride a bicycle, we have a car, and we also, I guess footwear was originally designed to protect your feet. If you're going to walk across the hot lava to find a meal, you're going to have to protect your feet. Now, we've taken this to the nth degree, and you've seen some of these things that maybe, I don't know, I don't even know how some of these ladies can stand up on some of these high heels that they have, these stiletto things. Is there anything that would indicate that something like footwear could influence circulation, could have an impact, good or bad, on veins?
There's a lot of talk about that in the public press, and I'm not quite sure what they're saying. But as the things that I'm familiar with about that seem to implicate the fact that when you're standing in the high heels, you're not flexing your ankle very much, and so you're maybe not working the muscle pump as well in the calf.
Which is helping that blood get picked up by the veins and get back up to the heart to get dealt with.
Yeah, no,
I get it. Okay.
That's a popular concept, I think, but I don't think there's any really good scientific data behind it.
Yeah, they talk about muscles and things. A lot can be affected by that.
There's
maybe.
a lot behind that.
Yeah, but I'm not sure, are the veins even aware, except I do know that a lot of people self-diagnose and treat like I do and elevate my legs. Boom, you feel good right away. That's because the pressure's off you.
But speaking about that muscle pump, there is one thing that we do know, and that is that the frozen ankle, that is a lot of people later in life, either through arthritis or other things, develop a lack of movement of the ankle joint. And when that happens, then it is true that there's a lot of venous disease and very hard to treat and very hard to get it well. If people have degenerative things like sores in their leg related to the veins, these people do very poorly with the so-called frozen ankle. So,
yeah, let me ask you this about that, because we've learned in the past, and if you haven't heard the show before, your heart is this wonderful big pump that pumps blood into your arteries and all to your extremities, all the way through your system under pressure. It comes back via the veins. And there are a couple of different things that help. One doc was just talking about is these valves, but there are actually, I guess, a couple of pumps that are in between the very bottom of your foot and your heart, helping you get back stuff up. And one of them is, like you often recommend if you're traveling, if you're not going to do anything, if you're sitting in an airplane, at least move your ankles up and down, because that's a pump.
Well, that's right. There's reservoirs of venous blood in the lower extremity. There's one in the foot. There's a biggest reservoir is in the calf and the calf muscles, and the third reservoir is in the thigh. And so of all of those, the major pump is probably the one in the calf, so that when you flex your foot up and down, move your foot up and down from the foot to tiptoes and then back.
And I'm doing that as we speak. I can feel that pressure that calf muscle has.
Yeah, feel that calf muscle. Sure. Okay, so everybody in the audience can move their leg up and down.
Okay, now that means to me, if you take a look, gang, at what we talk about, the visible veins, or these little spider veins, I'm not sure that they're impacted by that calf muscle. You're talking about these veins, you're talking about are the inside veins, the main ones, and they're the ones that are getting compressed and released by this calf muscle flexing.
I think the way to think about it is that as you flex that calf muscle, make it real hard, it's like squeezing a sponge.
Okay.
So when you squeeze a sponge, it goes out everywhere, right? Mm-hmm. All the water goes squirting all over. Well, in the venous system, there's a beautiful anatomic and physiologic mechanism that causes that blood to flow out of a reservoir of blood that's contained in the muscles, and then it's directed from the surface to the deep veins, and from the veins at the foot back toward the heart. And it's directed in all these ways by valves. These are one-way valves that allow flow in one direction and close to prevent the flow backwards. It's key to the whole thing, and it's massively organized from the tip of the toe to the groin, where all of this blood is directed back toward the heart in an orderly fashion, from surface to deep and from distal to proximal.
Okay, and it's like, gang, like you see these salmon swimming upstream. They just keep swimming up, and if they stop swimming, they slip right back. They go all the way back downwards. So if your veins are like that, if these valves in your veins stop functioning properly, that blood doesn't go up like it's supposed to. It'll pool around you. Now, before we go on, I saw this question, which I think is terrific, because we kind of covered this. And before we get into the real problems, let's talk about this thing called economy class syndrome. I saw a story in the paper just the other day about how some of these airlines, in an effort to create more overhead space for your carry-ons and more revenue for this, they're putting more seats on the airplanes, which are squishing us up. And now we're in a awkward position for if you're traveling from the East Coast to the West Coast for a couple of hours, several hours, with no movement and cramped conditions.
Yep, and so that is true, and that is the thing that medicine is implicated as a possible cause, a contributing cause for developing new blood clots.
Yep.
The longer the flight, the more likely you are to get a blood clot in your leg. The older you are, the more likely you are. And there are all kinds of risk factors, such as varicose veins, other diseases, inability of your legs to move, lack of motion, and so forth. Seem to summate if you sit for 4, 5, 6 hours on an airplane flying over the ocean. And at the other end, you may get off with a blood clot in your leg. How often
do you sometimes, Doc, have to advise patients not to fly? Are there at times when, if I'm at a certain point of vein disease where it's just not a good idea to fly?
Yeah, if you have people who have active blood clotting, then you certainly are careful. And even after certain operations, you want to take pretty careful recommendations to the individual about flying and how to fly properly.
How do these clots, particularly on a flight, you are, I guess, self-explanatory. If your pump's not pumping that blood and you have some valve issues, you might end up with developing a very rapidly developing clot. How does that happen anyway? What is how do they develop?
Well, what happened? Well, how does a blood clot develop? I think that's what you're asking, basically, and specifically on the airplane. Well, how a blood clot develops, there are a lot of different ways, but the most frequent way we think is that a blood clot develops through a little valve cusp in the lower part of the leg. Actually, in the calf of the leg, where we have many, many valves sitting there waiting to direct the blood flow. The blood can become stagnant in the base of that valve.
That's the physicalness that happens. It starts to become solid. It stops moving like it's supposed to.
Yeah, I think the best way is to think of it as a little pearl, and in
like that
shell.
grain of sand in the oyster.
Grain of sand.
Yeah.
Mm-hmm. And so, and there's some data about this, but if you start with a little tiny pebble in a cusp, the valves, they're called bicuspid valves. That means there's two cusps, and if you picture a round tube, which is the vein, you'll have a cusp on one side and a cusp on the other, and they gently meet in the middle. Well, they form a kind of a cup underneath, and we call it a cusp and a cup and a cusp. But in the bottom of that cup, the blood flow isn't as rapid and as active, we think, as it is in the flowing stream.
Okay.
And there are certain factors in the way the blood flows that allow some blood to actually, most of the blood goes upward. But in a properly functioning valve, some of the blood deviates back and goes along the sidewall of the vein and cleans out that cusp. I mean, it's an incredible thing.
Which is supposed to be, if that happens on a regular basis, that's good news. Keep them clean. But it may be if you're just sitting still. You're not getting good clean. I was thinking of that. If you take a look at a stream, if you ever have the opportunity to be at a stream, sometimes they can be pretty fast flowing, and yet on either side of the stream there might be stagnant water. And you just wonder, how come that water isn't moving like the other water? Well, that means that there's something blocking it. In this case, it's a valve that's not functioning properly.
Yeah, if you'll watch a functioning stream, I walk by a culvert where the water is flowing down into the ocean, and it's very interesting that as the tide changes, so does the appearance of the sand at the bottom end of that culvert. And when it's really flowing, you'll see the sand dig out a little hole. At other phases of the tide, that hole fills back up, and it's constantly filling up and so forth. So some of this is very analogous to what's going on in the veins.
Okay, now, are there any particular age groups that are more at risk than others? I mean, one would think if you get a nice young kid, 7 or 8, 10 years old on an airplane, that they're not as likely to develop a blood clot as their grandparents. Is it age related?
Absolutely. That's one of the most major things is age, and that goes all the way out from infancy to 80 and 90 years old. So the older you get, the more likely.
Yeah, I know that we've talked in the past about out of the ordinary cases where someone young in their teens would have pretty serious venous disease, but I do know that there's that group, and I guess it's the group that watches TV the most, the 29 to 54. You better start thinking about it. So what is that? I mean, what age does the risk kick in, and how does it worsen as we get older?
If you look at a curve of it, there's almost none of it up to teenage. Very little of it in teenage. Young adults in the 20s and 30s and so forth get into childbearing age and various activities, maybe more less active at those ages than they were as younger people. But anyway, you begin to see some blood clotting in the 20s and 30s, but still very unusual. So if you see that, then you begin to look and think, well, do they have something wrong with their blood or some kind of disease that makes them hypercoagulable, more likely to coagulate? Then you get into the 40s, 50s, and 60s, and so blood clots, that's when you might see blood clots in people that are flying or people that have been sick for a while and are normally well. Those kinds of things or an operation, orthopedic operation. Then when you get 70, 80 in the Medicare years, that's when the incidence really goes up. And so what brings that on is probably a myriad of factors, or the patient's condition and the health of their tissues and the vigor of their circulation.
Yeah, and some of you have heard comorbidities. I mean, maybe the more things you have going on in your body it heightens the risk. Now, we do know, and you've talked about this, that although we're talking primarily from the ankle in the calf as where most of this stuff shows up in the beginning, I know that a big person has this big belly in the front of him, and that might hurt him. But what about pregnancy? I mean, I know this is an equal opportunity disease, but it seems like I think a lot of our listeners think that this is a woman's disease. And I think they think that because of this cosmetic nature of
early
venous. You mean
pregnancy or vein disease?
Yeah, well, yeah, both really. But honestly, are pregnant women more at risk for blood clots than a non-pregnant woman, for instance?
Oh, I think so.
Yeah,
I think so.
And what would be the reason for that during the pregnancy?
We don't know.
Is circulation different than when you're not pregnant? Well, obviously, it's kind of neat when you think of it, Doc. Because you got this little fetus in there that's getting its own system built up, and mama's blood's going through there. I mean, mama's blood's doing a lot of extra work during this period.
Well, it is. There are very little pumps in the baby too, but in the fetus. But, we probably think that the most likely thing happening in pregnancy is hormonal changes having some effect on the blood vessels. We know that the blood vessels do dilate during pregnancy. So the particularly lower extremities vessels dilate. I mean, just like the breasts enlarge, all kinds of certain physiologic things happen. But in the legs, the veins will dilate so that a lot of women during pregnancy will develop enlarged veins. If their veins are normal and normal architecture and have functioning valves and so forth, they probably involute and go back to normal after the pregnancy.
Yeah, we've mentioned that before, and we've had some case studies and some patients with us, women that went through multiple childbirths in their child-rearing age, and they attested to that. Yeah, they had more, the veins were more protruding when they were pregnant. And when they're not, I guess the pressure's off. So, your veins can return to whatever normalcy is.
But it seems like more than pressure. We can't explain it on a pressure basis. Yeah. And there's something in addition to that. And what factor X is, I don't know.
Okay, now, so we talked a little bit about the age as we older and pregnancy. Now, I do know that there are a lot of different parts of medicine where there are tests, where you can self-test. You can take a look at an eye chart and think, I better go see an eye doctor. Women are taught from their 30s to do breast examinations so they can try and deter early lumps and things. You look in a mirror, you have a tooth hurt. What about self-examination for venous disease? Outside of the surface, which you can see, is there anything you can do to sort of wonder if you've got a condition that needs further help?
Yeah, well, you think you can see the veins so you can tell when something's wrong. Not true. You can see some of the veins so you can tell what's wrong with them, perhaps. But you don't see the major veins, which are buried down in your tissues. So the two symptoms that you want to look out for relative to veins are pain and swelling.
Yeah, and swelling being the key. Now, the interesting thing was every time that we talk about this subject a little bit, I think there are a lot of things that cause pain, and there's certainly a lot of things that can cause swelling. So I guess that when you're doing your diagnoses, whether it's your family practitioner, your internist, or whatever, you start eliminating some of the things that might have caused that symptom and narrowing it down for just a few. By the time they get referred to a venous surgeon, is it pretty much a given that that's where the problem is?
No, it's a suspicion.
Yeah, I got you.
So
Needs to be corroborated.
So I think the phrase that embodies when do you suspect that you got a vein problem, either you or your doctor. If you get unexplained pain, let's go to pain first, but it could be swelling too. If it's unexplained in one leg, and it lasts more than a couple of days, and so the normal things you do about a sore, you've done that and it didn't work. And if you have pain or swelling, then you might think, well, maybe are my veins okay? If you have pain and swelling, and you didn't have that before, then you want to think more strongly about the veins, because, pain has a myriad of causes, and swelling does too. But swelling, if it's a systemic problem, that is, if there's something wrong with your nutrition, or you're overweight, or even if you have heart or kidney disease, that should affect both legs.
Yeah, gang, so you got to write this down. One of the tells, if you will, is one leg. Now, Doc, I got to tell you, though, we had one case study here a while back where you brought in this young guy who'd been treated for many years and had absolutely horrific varicose veins in one leg and not the other. And because in one leg, he didn't have any valves, so his legs were all jammed up. The other leg, the valves are okay. So the question begs, when you talk about this, the self-examination part of it, can you tell by feeling? The one leg being swollen is that separates a lot of the questioning, doesn't it?
It raises the suspicion that it's...
Yeah, but what I'm getting at is, let's say you go ahead and you get that treated. Why is the other one not doing it? Because you think the two systems are the same in each leg, but apparently they're not.
Why is the other leg not swelling?
Yeah.
So that's what you're looking for. You're looking to see if there's an obstruction in the vein that's like a silent blood clot down deep, or whether you have particular valvular defects. But the valvular defect wouldn't come on as suddenly. So if you're a well person and then suddenly one leg starts to swell significantly.
Key point, yeah.
Yeah. So that's a change in things. If it's more chronic, well, then you don't know. Now, we do see people, it's not too rare, to see somebody with one calf a lot bigger than the other. And you wonder, and then you look at the veins, and they're all okay, and you think, well, what is it? Well, often that's due to atrophy of one part of the muscle in the leg. It was called the gastroc muscle, great big muscle back behind your leg that's a part of that muscle pump. Not too rare for something to happen that during life. One of the things even is polio affecting a leg. But something can happen to one head, we call it head, but one side of the inside or the outside part of that gastroc muscle, and it can atrophy, and very subtly. But then there's a very major disproportion between that leg and the other leg.
Now, I think that most of us, if we get a condition and one leg swells up more than another, you can actually see it. But are there some people that are just unaware that one leg might be an inch different than the other leg? That's a lot. That's a big difference, isn't it?
One of the key questions is, what is an important difference?
Yeah.
Is it half an inch, is it an inch, is it 2 inches, or what? 1 inch is a good marker. Well, the two legs should not be 1 inch different in normal people. Now, that's not to say it never happens, but it would be very rare.
I got in a long debate one night with a relative who has been for many years a shoe rep. He's represented shoemaking companies to retailers. He sells tons and tons of shoes. Nobody's 2 feet are the same. One foot's always a little bit bigger than the other, but imperceptibly so. So when you buy a pair of shoes, they're pretty much the same size. One of them is going to be a little tighter, and I've actually, since I learned that, noticed it. So that's something that I guess you come to embrace. But then when it changes, then you have an indicator. That's why I'm trying to get the people that are listening that say, gee, I think my leg's a little bit bigger, and gee, now it is a little bit bigger. Do people actually measure their legs?
They do not, but they look at their legs, and so they may look, and so it's kind of interesting how you look at a leg and when you measure it. Often what appears to be an enlargement turns out not to be a measurable enlargement. Okay. But sometimes people feel a tightness or stress in one leg, and they think it's swollen, and they'll say, well, I have a swollen leg. Then when we measure it, we can't get the difference. Now, something's happened to that leg, and the person has a different perception, but it's not a measurable swelling.
Yeah, and you can always, I know that quite often if you hurt a hand and you put one hand up next to the other, one finger up next to the other, you can tell.
Yeah.
When one's swollen, you can tell. But that's because you have an awareness level because you're using that all the time. And a lot of us, Doc, and particularly depending on where you live and what time of the year it is, you're all covered up all the time. So you don't really maybe notice unless it is when you put a pair of socks on, when one sock is tight and the other's not, you think, something's wrong with the socks? Not probably. It's something wrong with it.
Yeah. But so people don't panic about all this sort of thing. There's also time, so that if you just get a little enlargement or discomfort in your leg and wherever, your foot, your leg, whatever, and it goes away in a day or 2 days, or you do something and whatever simple thing you do, take a hot bath or cold bath, whatever, and it goes away, forget it. But if you have something that you do the normal things for and you don't get a response and it lasts 2 or 3 days, that's the time when you want to go see your doctor.
Okay, now I know that, this might be jumping forward a little bit, but we talk about, a clot. And you can't see a clot necessarily, but once you get the symptoms, like you're talking about, the pain of the swelling, get it diagnosed. But I also thought there's another condition that happens further along in venous disease, which we sometimes talk about, and that's not just a clot, but it's an actual sore that won't heal on your leg or a leg ulcer. Is that really telltale as venous disease? Can you get ulcers in your legs, lower legs particularly, that aren't venous related?
Okay, well, now we've moved. That's a big
I know
jump.
it's a big jump forward, but I just got curious about it.
So, what's your question about the clot? Can you tell whether it's a venous clot?
Yeah, only because...
I mean, a venous sore?
Yeah, yes.
Okay.
Yeah.
No, you can't.
Yeah.
They can't. But the doctor should. The doctor should try to tell that because it makes a big difference how you handle it. Mm-hmm. And so, this requires ultrasound examination of the leg these days.
The reason I asked that is because you talk about something that has a start, beginning, a middle, and an end, which is like when you get cut, you bleed, and then the bleeding stops, and pretty soon there's a scab, and pretty soon the scab falls off, and that particular incident in your life is over with. But some of these leg ulcers that I've seen, and I had one, so I know this, people just don't realize how much time has transpired. And is there any other reason why an ulcer wouldn't heal besides a venous disease?
Well, many.
I get it. Okay.
Many.
So it's not a given. Yeah.
No. Well, so a sore on your leg can have a myriad of causes, but we have some statistics about that, and they're pretty interesting, and people should know about them. If you get a sore on your leg or your foot, so the leg is not the foot. The leg goes down to the ankle, and from the ankle out, it's the foot. Okay. So if it's in the foot, the chance of it being a venous cause is very low.
Interesting. Yeah.
But the chance that it's an arterial problem is very high.
Which is maybe a symptom of something like diabetes. Yeah.
It can be a complication of diabetes or hardening of the arteries as people get older. And then you talk about not enough blood supply down there to keep the tissues healthy. So you think of diabetes, you think of paralysis or neuropathy, something wrong with the nerves, where the patient, or even the diabetes, where you don't have the nerve coverings are deficient, and the patient doesn't feel. Then they get a sore and they don't recognize it, and it can go on and become really a bad sore and become an infection.
I marvel at that because I've met a few patients, and we've had a few on with us, and I had an ulcer based on a trauma. But it's amazing to me sometimes how long people will put up with something before they go get it help. And I'm not talking just about an ulcer. I'm talking about a swelling or an itch or a burning or a numbness or a tingling. They just live with it, and then they finally think one day, hey, this has been a long time. I got to get this looked at.
Well, that's true. So the dictum is you have something and you do the normal things for it and it doesn't get well, you go see your doctor.
Yeah, well, listen, if somebody's still listening to the program after all these minutes, they're interested. And if somebody's in denial, they're long gone, so we're not going to get at them anyway. But the bottom line here is, and I suppose that people want to, all right, well, what can I do? What are some of the things that I might be able to do to help either stop this thing from getting worse or deal with it, do it comfort so I can do my own thing? And that's what a visit to the doc's going to do, right? You're going to take a look and say, all right, here's a treatment plan. Here's what we can do to help you.
Yeah, and so the person you see is your primary care doctor because that's what they do. They separate the wheat from the chaff for you, and then they may send you on to. They'll decide whether you need to go see an orthopedist or you need a new pair of shoes or you need to go see a heart doctor or a vascular surgeon, whatever. And so you can't make that decision as just a regular civilian because you don't have the basis for it.
Yeah, and there's a lot of people who say, well, he's the quarterback. But I'm actually, now that I do football analogies a lot on my regular show, thinking he's not really a quarterback. He's more the offensive coordinator. In other words, he's going to determine what play is going to work for this particular circumstance, or what you call presenting. And I would imagine that the best friend to a venous specialist is a general practitioner or an internist that really understands what to look for in certain diseases like vein disease.
Yeah, there's a lot of interplay back and forth, and there needs to be more that the primary care doc and the general doc and the specialists, particularly in vascular, need to communicate about what's going on and why it's going on. And there are things, the ongoing care is in the hands of the general doctor and the primary care doc. The episodic care for something that goes wrong, that goes to the specialist.
Yeah, but it seems to me that there's very little over-the-counter right now in the U.S. that is dealt with. In other words, it's not, okay, here's what you got, here's this prescription, go down to Long's and take this for 10 days and you're going to get better. What you're talking about is real treatment. But there are some things, and I brought in a couple examples of them today to talk about where people can ease the pain and suffering a little bit.
Oh, yeah.
On their own.
Yeah.
Yeah,
a lot of aids. What did you bring in?
Today I brought in a couple of things because what Doc and I often talk about compression, our leg wraps. We talk about elevation. We talk about proper footwear. Talk about a lot of things. Huh? Today I saw and the biggest complaint about the compression hose, which we'll talk to you about, is some people perceive that they're very, very expensive. And I'm thinking we have to get people to think this is not a pair of socks. This is a medical device. And once you can do that, you can understand why. But there are some people that are making socks that they call compression socks. And I showed you this one ad for them. And it's like 8 pairs for $20. So you said, first thing you said was, well, you get what you pay for.
Well, that may be a good
I'm
buy.
buying some of them just because they're cheap.
Well, that may be a good buy. It may be a waste of money.
Yeah, exactly.
Depending on why you're going to use them. But if you want to keep your foot warm, that's probably good. If you want to treat swelling in an intelligent way, it may not be the way to go.
Yeah, I do know that if you've played sports, and most of us have, that at some point in time you had a ace bandage on an elbow or an ankle or a wrist or a knee, and I thought, well, just keep those things because they're great for veins. And turns out that they're really not.
Well, it is a time to talk about because people may have some swelling, and one of the things we learn early in life is to wrap an ace bandage around it, right?
Compression.
Yeah. And so, and that does a lot of things good because it keeps things from swelling and protects them from the outer environment. But it's not a good compression wrap because what happens with ace bandages is that part of it slips and part of it gets tighter, and so you get alternating tourniquets and loose places, and it is not an effective compression.
You want a nice even compression.
So you want an even compression, and that certainly comes from stockings. And so I'll call them stockings because they're more. I think of socks as ending at the ankle, but stockings should go to the knee at least, and that stocking, when it goes to the knee, if it's going to be tight around the ankle, it's going to be very difficult to get over the arch of your foot, where the arch and the heel, that diameter becomes the biggest diameter in the extremity in the lower leg. So, if you're going to get something tight enough to be effective at the ankle, or just above the ankle, then you have to pull it pretty hard to get it over that.
Yeah, and I've noticed that, and there's techniques and tricks for that. So it is unlikely that a pair of socks that are the same,
right,
the same, stretchability, if you will, all over it, because it looks to me like the ones that I have that you prescribed and that I went and got, and this is going back over a year now, is that they are at different parts of the sock thicker or thinner. In other words, it's like a spillway. It's not tight at the bottom and it's tight at the top. In comparison, and you know what I'm getting? The material at the top of your leg is thicker than it is at the bottom of your leg.
Okay, but the important thing is the medical made stocking is woven or made or manufactured in very precise ways. For instance, the heel will be weaker sort of material, so so it can stretch out. The toes will be weaker. The major strength will be in the lower calf and extending up, but that's not. Look at your ankle and then look at your upper calf. Those are two very different circumferences. Sure. So an awful lot has to go into the making of a stocking. Now, all of this works around to certain standard, and there's a standard in the industry, and that standard is a part on your inside of your leg where the big muscle becomes a tendon, and so it changes down in the lower third of the calf. And we can measure that pressure. It's called interface pressure, so that when the stocking is made, it's made to us at a certain standard on a model. That's not your leg, but that's the standard. Yep. So it's the best measurement we have.
Now, that being said, I do know that sometimes you'll see, and gang, I know you've seen these out there, you'll see people that have these things that look like ace bandages, just because of the color and the texture of the material. But they're actually wraps that are adjustable to make them tighter, and as the day goes on, you may need to make them tighter or looser. They're cumbersome. Are they effective?
You're talking about the Velcro wraps?
Yeah, it's the big things.
So Velcro is a wonderful thing, and there are some very well-made garments for the leg, which go from the ankle to the knee, and then there's a different thing to go over the foot. So it's separate. But these things can wrap around your leg. Now, they have one huge advantage over socks, and that is that there's you can change the amount of compression. Mm-hmm. So you can pull it tighter or you can make it looser. If you get a pair of stockings, you'll have a certain compression, and that's it.
And I was going to say, as the day goes on, regular ones, inexpensive ones, they stretch out. The better ones, like the ones that I have that are prescribed, you put them on at sometimes I'll put them on at 4 a.m. and take them off at 4 p.m, and it's the same pressure all day long.
Yeah. Mm-hmm.
Which is what you want, right?
That's right. Yeah. And so you want it to prevent the swelling, and if it prevents the swelling, then it does stay the same pressure. But the stockings are a very important industry. They're made very well, but they can't fit all circumstances. And you ask whether the garments play a role. They do play a very big role and an increasingly important role. You know, if we're going to put a bandage on somebody with a bad sore in their leg, we put a wrap on their leg where the professional molds the wrap to the whole extremity. And that way you can vary the pressure up and down as it needs to be varied. So the next thing that approaches that are these garments.
Yeah.
And stockings are third.
Yeah, and I can tell by previous experience that once you get used to these things, and depending on where you are, they can really, really be beneficial. Obviously, you want to think, will they cure something? And I guess the unfortunate answer is no, that they won't cure it, but that it will give you a comfort level so you can go about your business.
Well, let's talk about that for a minute, because if you have a swollen leg with an ulcer in it, the first thing that most people will do is treat it with antibiotics.
Yep.
The first thing that most people should do is treat it with compression and get rid of the swelling, because much of the time the problem does heal and go away just with compression. And antibiotics are often not indicated. Now, when they're indicated, they're strongly indicated, so you have to get that. But the professional needs to make that judgment. So the point is, swelling in the lower leg is not a good thing. You want to have that under control as first part of your treatment. Are there,
when you say treatment, are there medications that can cure varicose veins or help cure?
Yeah, that's a good question. And to cure varicose veins, not the ulcers. Now we're talking about the varicose veins.
Back to veins. Yeah.
Well, there are things, all kinds of things in various literature saying they make veins disappear, and whether they're just cosmetic. I think some of them think that they can even make varicose veins go away. I don't think there's any truth in I don't think there's any. There is truth that some of the medications can make your leg feel better, and some of the veins can be managed so that they function a little bit better. So slight improvement. However, it's not enough to convince the FDA to approve these medications in the United States, so we don't have to deal with them very much.
Yeah, and one would think that obviously everybody would be working in that area. I'm sure that, in some of these pharmaceutical houses, there's great studies saying, gee, this is a huge growing section of the society if we could only work on something that would help.
But one of the big problem is that what's happening in varicose veins, it goes back to our first discussion, what's wrong with them. Something happened to the wall of the vein and it got weak. And we don't have a medication that's going to make that wall stronger or the valve function better. Yeah.
Well, so in many cases, the treatment indicated is surgery, and this is something that you've been doing for decades. And I suppose, Doc, that the biggest question comes up is, all right, will the surgery cure that vein? And I've learned from you that the answer is no. It's going to make that vein get replaced by a different one. You're going to figure out a different system, because once that thing is clotted or once that vein is damaged, it's pretty much done.
There's one thing that you can fix, and that's a valve in the bigger veins, so they can be repaired and they can function for a long time, but it's a significant sized operation. Other than that, for varicose veins, the treatment is always remove the vein or make the vein dry up, so-called dry up. That is, we can inject things inside the vein that cause the inner lining of the vein to come loose, and then the vein will develop a blood clot in it and heal shut.
Shut up.
And it goes away.
But here, the fine line, and I know a lot of people ask this right away, is that particularly now with the ever-changing face of healthcare, there are things that are considered cosmetic, and there are things that are called symptomatic. What if your doctor says these are only cosmetic? What are the options cosmetically? I can elect to have cosmetic surgery done to make them appear to be gone, or I can live with them. That's a decision that I guess the patient has to make based on either an estimate of what it's going to cost or how bad does the look bother them.
Yeah, the difference between cosmetic and therapeutic treatment. Well, I look at it this way, and that all surface veins have a cosmetic value.
Sure.
And so, and for different people, some people just can't stand the appearance of a vein in their leg.
Oh, in previous programs, folks, we've talked about this, where we get self-esteem issues. We get people that stop doing activities because they're embarrassed about the way they might look. Their personalities can actually get altered by this, by an appearance.
That's true.
Yeah.
And it's valid, and so that's worth addressing. And it's a big industry if you want to call it, but a big business in treating those veins and treating them well. So that's good. On the other hand, it's not medical. That is, it's not something that's going to make you sick if you don't do it.
That's one thing that I've learned. That's the key. Make you sick, and sick can be described as
function.
Impair you, so that if you are a salesman and you can't stand up all day and do your job, that's a sickness. You have a disease. Your legs are not working right. It's impacting your ability to exist and earn a living.
Yeah. Now some of that can be psychological, because if you earn your living by showing your legs off in one way or another, well then.
Not many of us guys have that experience, but some do.
Well, some do.
I actually have a friend who is, although he hates the expression, he is a male model. He's an executive. He's a CPA by trade, but he also is a nice looking guy, and he models, of all things, underwear. So your legs got to look pretty good.
I think it's a valid thing, no question about it. But also, and women, are so conscious about their veins, but that's more self-image than it is. They're not getting paid for it in general.
Is there a fine line, Doc, where sometimes, as a professional, you have to make the call that concern is just as valid as a sore or a pain?
Well, but insurance companies have to have rules and regulations, and so they draw the line.
They're a little colder.
But I think by and large they try to take the patient's point of view, and as long as where we have no problem with insurance companies validating treatment is if you have symptoms in your leg. So you have pain or something, and swelling or whatever. But if we can demonstrate that some of the valves are not functioning perfectly appropriately in the leg, then there's no argument with insurance.
Yeah, well, let's circle the wagons and go back again. We know so many people that have retired, and then for one reason or another, either they start running down their finances or they're bored and they want to get back into the workforce. And that requires being able to maybe be more physical than they've been for a while. And that may be an issue that, gee, I need to go back to work, but I really can't. I'm not comfortable. I'm standing in, I'm a greeter at a big department store, and after a couple hours, I got to go lie down somewhere. I hurt.
Yeah, so the reverse of that is a lot of people change their job because their legs are not comfortable.
Sure.
But those are all valid reasons that your insurance would take a look at.
Is generally the answer you get from the insurance company pretty quick? If somebody comes in with a condition that's going to require treatment, does the insurance company pretty much, I guess, based on the reputation or the or the knowledge that they have of the practitioner or the specialist, you can pretty much know right away, yeah, this is under your health plan, this is covered?
Well, I think you'd think that it was very objective, but there's a lot of trust that goes back and forth between the insurance company and the practitioner because you can't prove everything. So if you have pain, I can't prove it. You can't prove it.
Yeah.
It hurts you, but you can't measure it and see it.
I can tell you, though, that under examination, when somebody is applying gentle or heavy pressure to evoke a pain response, that a good practitioner, and I certainly know that you can, and many of your peers, you can pretty much tell if somebody's, faking a pain or a soreness. You can probably tell that a little bit anyway.
Well, I think it's very difficult because if a person experiences pain, I mean, who am I to say you're not experiencing pain? I can't. And so even if I'm not touching you, if that hurts you.
Yeah, but now there's this wonderful thing called the ultrasound, and that'll kind of show you how bad something is inside.
That's exactly right. Yeah. So that gives the lie to the person that's trying to deceive. Most people aren't deceiving because most people consider it a waste of time to go sit and wait in the doctor's office. I mean, that's not what they want to do.
To roll the dice, and they do that at the casino. But I think that what we're trying to do here is let people know today, and I think we pretty much covered it as to identifying the fact that this is a separate disease. It's different from a lot of other things that can happen with your body. There's different treatment. There's no real medicine or pills you can take at this point. So if you get to a point where you need to see a venous doctor, it's probably going to be a venous surgeon at some point.
Yeah, that's right. And so there's no magic pill. There's no magic cure. But, proper diagnosis and specific treatment can make a world of difference to people. So it is worthwhile checking it out with your doctor and seeing whether there's something to do.
Yeah, and there's another thing, and that is that I know because Dr. Kistner and I have had a lot of talks about this and done a lot of programs on it, that in many cases, when you start taking care of yourself as a result of getting varicose veins that need surgery, there are a lot of things, other things that are not 100% right with people, and it gives them incentive to work on some other things so that they can climb that mountain again instead of just watch it.
You mean getting in shape and
Absolutely.
Getting rid of obesity?
Yeah, and getting obesity, maybe watching the sugar intake, maybe not having quite so many glasses of wine at night, maybe going for a walk after dinner instead of...
Wait a minute, Mike, you're taking all the fun out of life.
Yeah, well, we don't want to do that. But we do want to thank you for listening today and hope that you've learned something of value. We ask that you come back again and join us at another time. In the meantime, if you'd like to hear something specific or you want to know a little bit more about something we do, give us a call at the Kistner Vein Clinic, or easier yet, just get online. Go to Kistner Vein Clinic. That's Kistner, veinclinic.com. So for Dr. Kistner and everybody at the clinic, I'm Mike Buck. Thank you for listening. We'll certainly see you at another time right here on Healthy Veins, Healthy Legs.
Thanks for listening to Healthy Veins, Healthy Legs. For more valuable information, visit us online at www.kistnerveinclinic.com.